Good morning, folks. John Adamson, the Rehab and Documentation Guru, redoing a video that somehow just went bye-bye. I cannot find it. So, anyway, a really interesting case study the other day, and I'm just going to recreate some of the content from the other video. Have you ever had those moments in your career where you've had completely satisfying one visit outcomes? Things just went super well. You were astounded, literally astounded at just how successful things were. I've probably had a handful or so in my 30-year career as a PT. And yesterday I saw a patient with BPPV, benign paroxysmal positional vertigo. Back in the day called school, I really don't remember learning that term, and I didn't look up how long that term has been around. I know it's been around for a while. But we really didn't learn to address it back in the day called school. Well, probably about 10 years ago, it's probably close to that. Aegis Therapies, with whom I worked as a clinical specialist in an area, developed a course for BPPV, or at least some training related to it. And it wasn't going to make you like an official, it wouldn't give you a designation of a vestibular rehab specialist or anything, but it was to give an introduction and basic treatment techniques to the clinicians. We didn't have anybody to train it in my area. I'd never done it, so I went about educating myself, and I studied and prepped, and I presented the course. And I was teaching it theoretically. I knew what the cannulas did. I knew what positions they were in. I knew what the tests were saying. But I'd never seen a patient on my own with BPPV. So fast forward a few years, and I'd seen a few here and there, but most of the time, by the time I got the patient, they'd had it for months and or years with improper treatment. And if you've done vestibular rehab, you know those patients. Generally, at that point, you're just teaching them to accommodate. But yesterday, completely satisfying patient interaction. Elderly, we'll just put it that way, with comorbidities. A relatively low ejection fraction, one that does not need transplant, and one that does not need an implantable device for pacing or for defibrillating, but impacted by that. And she's got other comorbidities like PAD. She had a carotid endarterectomy. No, I'm sorry, she did not. She's a different patient I'm thinking of. She was cleared for her carotids, but she does have PAD in her limbs. And of course, we know she has CAD. So anyway, the day before Thanksgiving, was rolling over in bed during the night because she was going to get up to go to the bathroom, and the room just started spinning. She rolled to the left, and the room started spinning. And she said she threw up, and anyway, she went to the hospital because it was so bad. And she said 5 days they couldn't figure out what was going on. At first, they thought she had a stroke, which just shows you that the differential diagnostics that were done on her were pretty limited. If just a waking up, a turning, and causing the spinning is what sends you to the hospital, you would think somebody with some knowledge of BPPV would say, well, maybe it's this. Anyway, eventually, in the hospital, they determined it was BPPV, and one of the hospitalists put her through what he called Epley maneuver. Didn't do anything. They sent her home with home health orders. The nurse went out and did the case opening and had the patient do so-called Epley. I'm not exactly sure what she did. And I told the patient to do it 3 times per day. And, well, that's not appropriate. Too much. So then I got there yesterday. And she was very pleasant, obese, Definitely, you could tell she's probably got sugar regulation issues. I'm guessing she probably has undiagnosed diabetes. So anyway, I did first of all a cervical screen for vertebral arteries. Now with the elderly patient, well, she also had a neck fusion. She had C5, C6 neck fusion. So I knew she had neck restrictions. And that's something that's important when you're going to, treat somebody for BPPV. Anyway, when you screen the neck to make sure that maneuvers won't cause problems, cervical extension, as we know, would possibly occlude the vertebral arteries. But that's a pretty aggressive move, and I was a little loath to try that with her just based on her history. So a simple screen you can do that's less aggressive, and you can see how that goes first, is have them just lean forward onto their elbows while keeping their head forward, looking straight ahead. And that caused them to extend just less aggressively. Couldn't When she did that, I could not elicit any signs or symptoms. So I thought, okay, then we're probably okay. Then I said, okay, I want you to extend your head back slowly, because if it's vertebral artery issues, and I'd already asked her, is it dizziness or is it spinning? And she had said spinning, so I'm thinking, okay, it's probably BPPV, but let's make sure. So she went slowly, which wouldn't stimulate her semicircular canals, and no symptoms. So then I had her go ahead and throw caution to the wind and throw her head back, and sure enough, woo. So, and at that point, I was watching her eyes. And what you're looking for is nystagmus, the beating of the eye in a direction. Now, I'm rusty, but what I noticed was that she had left upward torsional. So you've got this upward beat with this torsion towards the left of her eyes. And so once I saw that, something in my, and based on her movement, I'm thinking, okay, is it posterior or is it anterior? So I looked up a picture and it seemed like it was posterior. So I'm like, okay, it's probably posterior cannulus. And I told the patient, I said, ma'am, I want you to know, I know something of BPPV and I used to teach a course on it, but that's been years. Have not put it into practice in a while. I said, so you and I are going to sit down and watch a little YouTube video together about it. And she kind of laughed and she said, oh, that's fine, that's fine. So she appreciated the fact, I think, that I was honest with her, but she could tell I knew something of the subject matter already. And so I looked up a video on posterior cannula repositioning, and sure enough, I had it accurate. I couldn't remember if it was going to be left or right. Sure enough, it was the left. So left posterior cannula BPPV, left upward torsional rotation of the eye, nystagmus. So she had about 10 to 15 beats of nystagmus, definitely a lot of sensation of nausea. So the Epley maneuver for that is you have the patient sitting, long sitting, and I asked her about her hamstrings, because long sitting is hard on the hamstrings, and her back was okay, but she had to support herself with her arms. But anyway, she's long sitting, and then what you do is you rapidly lie them back into supine while extending the neck with a 45-degree turn to the left. Now, because of the fusion and because I suspected, it's probably not a great idea to like force her into extension, I did a modified. So I just did a 45-degree turn rotationally without the extension. And we went boop, and sure enough, that nystagmus flared, and she was like, whoa. And she felt nauseous, but it passed within 10 to 15 seconds. You hold it for 30 seconds, and then I slowly, I think you're supposed to rapidly, but I just didn't feel like manipulating her neck. So, and I could tell she was a little stiff. And so I rotated her 45 degrees to the right. So that's the next position. She got a little bit of nausea. I I couldn't see nystagmus, but she was feeling a little bit but it went away quickly. 30 seconds in that position. Then the next position, which is the one I'd really forgotten about, is that you keeping the head rotated, you have the person rotate over towards their right side, and you're supposed to do it fairly rapidly. So we rotate her over to the right side, keeping her head down, and again she gets the nausea. I couldn't see her eyes, but I'm assuming she probably had nystagmus. It lasted for about 10 to 15 seconds, and then it was gone, and I just kept her in that position for 30 seconds total. So then what you do is you help your patient sit up. So I helped her sit up, and she felt fine. And she had this look on her face. I'm like, is everything okay? Because, I was a little bit concerned for her because she had been really bad before that. Furniture walking, very stiff necked when she moved because she was afraid to set off anything on her vertigo. And she looked at me and she said, "It's fine. The symptoms aren't there." So I said, "Great." So I had her do the provoking movements again, and they did not provoke it. So I said, "All right, just to be safe, just to really make sure that those rocks that are loose are in the right position, let's do this again." We did the Epley again, and no symptoms during the test. And we were like, "Oh!" It's one of those moments where I was just completely blown away. For those of you that watch my channel, you might be true vestibular rehab champs and have lots of experience in that. You go, "Oh yeah, that's nothing." Had that happen lots of times. You probably have one of the most satisfying jobs. If you see vestibular patients and you get that kind of results often, that's got to be completely satisfying. To put your hands on somebody with your knowledge and get them to just bang, they're better. That is awesome. So, what did I tell this lady to do as an aftermath? Well, one thing that I remember from doing the training is post maneuvers, you don't have them just keep on doing stuff like that. One is you have them relax, rest. So I told her no strenuous activity for the rest of the day. Two, you have them drink a lot of fluids. I cannot remember the exact details for that. It might have something to do with potential for blood pressure drops. I can't remember. But drink plenty of fluids. And then I said, don't basically follow my instructions. Don't do anybody else's instructions. Because I was the only one successful. So I'm going to assume that what I did was absolutely correct. Because she said I didn't do anything like that when they were trying to do maneuvers with me. They clearly didn't know what they were doing. And I at least had enough base knowledge to go, okay, I think this is posterior cannulith. Let's look at the posterior cannulith repositioning. Because I could problem solve through the others. Like if the posterior one didn't work, I probably would have gone next to anterior and done those maneuvers. But at least I was exercising clinical judgment based on knowledge, and it worked. And I had one of those moments yesterday where I walked out of that feeling like high as a kite because I had really made an impact. And I think that's one of the things we like about our jobs is when we, not just because it gives us a chance to exercise maybe within a profession we love or care about, but when we truly evidence skill and that skill helps somebody to the point where they are completely satisfied. I think that's wonderful. Anyway, that would have been a good place to wrap up, but let me tell you what I'm going to do with this patient. I have 2 planned follow-ups, and I told her, the symptoms could come back. Just be careful. Also, they should come back with less vengeance, hopefully, if they do. And I said, we're going to just, make sure everything's good the next visit. If it's not, I'll come back one more. And if I haven't done my job and you're still having problems, then let's get you further assessed and get you to maybe an outpatient clinic where you've got somebody who has years of experience in vestibular. But I'm hopeful, very hopeful. She's supposed to call me today. So anyway, with that said, have a great day, take care, and God bless.